panel, we have two phenomenal, outstanding leaders of the field of tuberculosis and well beyond. And this here is really an opportunity to talk about a global health priority that's near and dear to my heart, as well as to two of my phenomenal panelists. Online is Dr. Soumya Swaminathan, who really needs no introduction, but I'm going to give her one anyway. I had the incredible pleasure of meeting her when she was first really working on both TB and HIV at the National Institutes of Research in Tuberculosis, which is a premier research institution by the Indian Council of Medical Research in Chennai, India. Without surprise, she rose the ranks and became the Director General of the Indian Council of Medical Research, which is the equivalent of the US NIH of India. And then during just before the pandemic started, she actually went on to become the chief scientist of the World Health Organization, and has now come back to India to run her family foundation that her family started. Her father, an illustrious scientist, was responsible for the incredible greening and agricultural sort of boom of India. And she's now the chairperson of the MS Swaminathan Foundation. And I could just say, sort of both having the chance to collaborate, but also sort of really seeing her as a mentor, as a role model in the field. She's just a phenomenal thinker, speaker, role model, mentor, sponsor. And I can't think of anyone better to come and really talk about the area of tuberculosis. She's a pediatrician by training and takes a lot of passion and knowledge about TB. And to my left is Dr. Richard Chaisson, who is truly an incredible giant in the field of tuberculosis. He's a professor of medicine and epidemiology, also an incredible mentor and sponsor for me personally. He leads the Center for Tuberculosis Research at Johns Hopkins University and has spent at least the last 4 decades really launching some of the most innovative clinical trials and observational studies that have changed guidelines multiple times over, particularly for TB prevention, with shortening of TB preventive therapy and really finding sort of ways to make things more accessible, more affordable. And importantly, you'll hear more from his recent role, being the chief of party for the Smart for TB Research Consortium, which is actually the largest research consortium ever funded by USAID. So USAID was a very bold and ambitious research agenda, and he will speak to, perhaps if he cares to share, some of the trials and tribulations, no pun intended, with the USAID's recent challenges. But he has resurrected it, and he's now continuing to really make waves again in the space. And it's so wonderful also to be seated here because I have several of my own wonderful colleagues and mentees and partners. My own mentor, Bob Bollinger, who was the reason I got involved with India in the first place. So thank you, Bob, for coming and really opening my eyes. I've got Samira Cox, Jyoti Matad, and world expert in TB in pregnancy. And we've got Jeff Tornheim, MDR TB. And what I mean by this is that this is an opportunity for us to continue to connect and grow and learn about this area. And Springy is here as well, who's just joined our team. So I want to first start with saying just a few other things, and then I'm really going to lead the floor to these two esteemed speakers. So first of all, how many of you have ever known somebody with tuberculosis? Just raise your hand. Wow. Okay, so when I'm usually in an audience in the United States, I never see this many hands raised. But that speaks to, because this room right now is filled mostly with people of Indian origin, either from India or second generation or third generation. Almost all of the crowd, Dr. Swaminathan, raised their hands saying they've known somebody with tuberculosis. That's very impactful. You want to take a guess as to how many cases were there estimated last year for TB? Just shout out a number. How many cases of new TB cases were reported, or I shouldn't say reported, were estimated to have occurred?
30 lakhs.
30 lakhs. Okay, that's 3 million. All right, 3 million, 30 lakhs. Anybody else? Going once.
26 million.
10.6 million.
10.6 million, okay, well, she's in the TV field, very close, 10.6, 10.8, depending on the degree. So 10.6 million cases, of which India represents 26%. So 1 in 4 people with TB were diagnosed in India. And so India really has an incredible, important role.
My estimate is the closest, I think.
30 lakhs is right.
Yeah.
Yeah.
That's right.
Oh, yes, oh, yes, I was saying, well, you're right, absolutely, absolutely, thank you, Rama. And coming from a computer scientist,
AI.
AI expert, absolutely. So, huge role that India plays in the global TB story, and we're going to hear really more about that. So I'll start with my first question to Dr. Soumya Swaminathan and Dr. Chaisson. Given some of the bold agenda and really a drive to work on TB elimination, not only just in India, but globally, from your point of view, what are we doing right and what can we do better? Over to you, Soumya.
Thank you very much. Excuse me, Amita. Can you hear me all right?
I can hear you perfectly.
Yeah. And thanks for the very nice words and of introduction. And yeah, it's been a pleasure working with you and many of the others you mentioned who are in the room, though I can't see them. So in terms of, tuberculosis today globally, and of course, I know that we have a focus on India, particularly in this session, but India being, of course, the highest burden TB country in terms of, numbers globally, accounting for 26% of the caseload, as you said. I think what's been good over the last, say, decade or so has been the increased global attention on TB, thanks to the work, of the WHO, but also a number of partners around the world and civil society. The civil society advocacies really played a major role. For example, I remember at the 2018 UN General Assembly, we had a survivor, Nandita Venkatesan from India, who had actually lost her hearing due to the use of aminoglycosides for her MDR TB. And it was very powerful because she spoke in the General Assembly, even though she was completely deaf, and said to the audience, even though I can't hear you all, she got a standing ovation. I hope you can hear me and people like me. She's also gone on to fight for, the patent, removal of the patent or the evergreening of bedaquiline and its derivatives and so on, along with the South African woman TB survivor. So I think there's been a lot more civil society action. I think we've set the NTB strategy has very ambitious goals of reducing the burden of TB, reducing death and catastrophic costs that we often don't talk about. But in low middle income countries, the catastrophic costs, the expenditures that families face due to TB, actually drives them into poverty, especially those that are just above the poverty line. So that is, so we have those ambitious goals, and a lot of countries have done a lot of things to make progress. And I think one of the good things that's happened is the innovation. I mean, starting, of course, with the CBNAT, which was our first molecular test that was approved by the WHO. We now have several more. Many of these innovations are coming out of India, but also out of other, low middle income countries. They're more affordable, they're portable, they are quite robust and user friendly and so on. So a huge amount of innovation. And the fact is that just before the pandemic, actually, we had achieved the highest rate of TB case detection, notification, and treatment. And the COVID pandemic did set us back. Deaths went up, and the incidence decline actually slowed. Now, what's not going so well, perhaps, is that our investment in R&D is really not enough. I mean, when I look at COVID and how much was invested in those couple of years, it was over $100 billion is estimated to have gone into, especially into vaccines. And the results showed we had vaccines, in less than a year. TB R&D, we've been very modest in our asks, and it's estimated we need about $2 billion, but we've never made that. It's always been less than half of what was needed. And the same story with implementation with programmatic delivery as well. We've only always achieved only about half of what is really needed. So this means that, innovations are slow to scale. We have innovations out there, but it's estimated that, only about a third of the people with TB in the world actually get a gold standard molecular test. Not many people get X-rays. A lot of them don't get the appropriate treatment regimen, and children, particularly with TB, are missed or misdiagnosed. We still have very high mortality. It's the #1 infectious disease killer. So considering that we've had TB diagnostics treatment around for a while, it's very sad to think that it's still killing over a 1.5 million people every day, over 300,000 in just India alone. And then finally, I think, again, as part of the R&D, we need more investment in vaccines. We have so many new vaccine platforms now after the COVID burst, in innovation, and we should really be fast tracking the development of vaccines, but also ensuring, as I said, the existing innovations we have, like the molecular diagnostics, reach everyone around the world. Sadly, after the pandemic, now we've seen that investments in health, in R&D, are going down, and this is going to have a devastating impact. Of course, the sudden withdrawal by the USAID of funding for TB and HIV diagnostics and treatment is going to have a devastating impact in countries that were dependent on that funding. But in the longer run, I think the slowdown in research is going to impact us negatively. So maybe I'll stop there for now, Amita.
Right, thank you so much for those really important points, and you ended on the sort of concept of research. So I know Dick will have some words to say about research and beyond. Over to you, Dick, about your thoughts on this.
Okay, thank you, first of all, Amita, for inviting me and for the nice introduction. And Soumya, it's so nice to see you on the screen here. Soumya and I served on several WHO panels 20 or so years ago, and I knew she was going places, but I didn't know she was going to be running the place as she did so beautifully for several years during some of the most challenging times. Anyway, pleasure to be on the panel with you, Soumya. So, as you mentioned, Amita, there are these ambitious goals that have been set. The WHO has set NTP goals that are extremely ambitious. India has set some pretty ambitious goals. And one of the things you have to ask is, when do aspirations become delusions? And it's pretty clear that the aspirations are delusional, but they're important. It's important to have goals. And you can measure progress or lack of progress against some benchmarks. And so if we look at those benchmarks, where there has been very good progress is with TB HIV-related tuberculosis, been a major decline in mortality, particularly, and a large decline in incidence, even though it still accounts for about 6 to 8% of all TB globally. But that's down from 12 to 15% a few years ago. So that's good. TB mortality in general and in India has declined nicely, not enough, but it's certainly declined. TB incidence really hasn't budged. And so why do we have such high TB incidence, and why hasn't it budged? My view is that we don't do enough prevention. And you have to prevent TB. Once a case occurs, it's too late. You failed at prevention. So I think the aspirations are a bit delusional, and we need to learn from them, learn what we're doing right. And TB HIV tells us some things about what we're doing right and what we have to do better. And for TB in general, mortality is declining because we have better diagnostics, we have better therapeutics, but we're not doing enough prevention. Even though we have very good prevention tools, we need better prevention tools, and ultimately a better TB vaccine. And I know there's a lot of work going on in India with TB vaccines. So I think in terms of, some of the really nice advances, the molecular diagnostics, as Soumya mentioned, are very important, and scaling them up is very important. But just, to think what's happened in the last decade, we've gone from TB preventive therapy that was a minimum of 6 months, and in many places 9 to 12 months, and we can now prevent TB with regimens that last 1 month or 12 doses. And that's pretty amazing. We just need to implement them better. MDR TB treatment, people don't have to go deaf anymore. It's, people don't have to suffer with terrible injections. People don't have to suffer with bad drugs that don't work very well. We have much better therapeutics now for MDR TB. So I think, just to respond to your question, we have a long way to go. We're failing in some areas. We're failing in controlling incidents. We need to do better at prevention. We have a lot of new tools. I won't comment now on the research pipeline, but I hope we'll be talking a lot more about that because that is a huge challenge now.
Great. Thank you, Dick, for that and for your thoughts on what's working and what could be improved. I'm going to change the topic a little bit because I think in the Indian context, the issue of nutrition and the role of nutrition, malnutrition plays both in risk of developing disease, response to therapy, and what can be done about it has been really a topic of growing interest. And of course, I know one near and dear to Dr. Swaminathan as well as to others in the room. Perhaps you could say something about that because, really looking at what we call the attributable fraction or the proportion of people who are impacted from TB with malnutrition being a risk factor is actually a very important one, perhaps even more important now than HIV, certainly in India. And there are other things like alcohol misuse, smoking, diabetes, et cetera. But Dr. Swaminathan, what can you say on that? Because there's a lot of attention and importance being given to nutrition and really trying to optimize that as a new strategy to address TB in India.
Yeah, thanks for that, Amita. I think that's very important because even though we've known for a long time that, there's a bidirectional relationship between undernutrition and TB, right from the First World War days when there've been observational studies of prisoners of war who were treated better than other prisoners of war, and incidence of TB between those groups differed. And analysis from around the world has shown what you just said, that the population attributable fraction for undernutrition is high, and particularly in India, it's almost 40 to 45% of TB cases that can be attributed to undernutrition. So that's just huge. And the fact is that there's still a large population in India that is undernourished, adult undernutrition in certain states, particularly in the north and central parts of India, and the tribal districts, or what are called the aspirational districts. Almost a third of adults might have a BMI of under 18.5. Now, even more fascinating, I think, and again, referring to the innovations recently, the rations trial that was conducted, that was supported by the ICMR and conducted in the state of Jharkhand by Dr. Anurag Bhargava and his team, found that supplementing the household contacts of TB patients in this quite poor and undernourished population, mainly tribal population, with adequate amount of calories and protein, a good amount of calories and protein, actually resulted in a very significant reduction in the incidence of TB amongst household contacts. And this is very significant because for many decades, as I've said, people have said, yes, the two are associated, but this kind of a randomized trial, well conducted, especially during COVID, it's, hats off to the team that actually managed to do this study, published in the Lancet last year, showing that for the first time in the world, that nutrition supplementation can reduce the incidence of TB. Now, of course, all TB patients in the trial were given the additional nutrition supplement because it would have been unethical to withhold that, and that's already part of the guidelines. But it also, the analysis also showed that TB patients who got this additional supplement actually had a much lower mortality rate than what was documented historically. So I think that's the first important point to note, is that we now know that nutrition plays an important role in the development of TB, predisposing you to get TB, that nutrition more or less acts like a vaccine to prevent you from getting TB, and that once you have TB, if you're identified to be malnourished, then you must receive adequate treatment. Now, for me, reduction of mortality once someone has TB should be our primary goal, really. And this would, of course, mean early detection and appropriate initiation of treatment and so on, but also means that you need good clinical care. And sometimes TB programs tend to think that all you need to do is to hand over TB drugs and this person is going to get better. And that's not necessarily true, because TB patients often have other comorbidities and complications. It could be hypertension, diabetes, it could be severe undernutrition, electrolyte abnormalities. So a study done in Tamil Nadu by the National Institute of Epidemiology showed that when you implement what's called differentiated care, so you have a checklist of, very simple checklist of 4 or 5 things which indicate that somebody is severely ill, you hospitalize them for the first couple of weeks of treatment and stabilize them, then you can reduce that mortality. And we know most of the TB mortality occurs in the first 1 to 2 months of treatment. So that's a very critical period. So I think bringing a clinical, though we know that TB is a public health program, but we mustn't forget that these are individuals, they're patients, and they also require good clinical care. And an important element of that is nutrition.
Great, thank you. And thank you for really sort of spearheading the rations trial with Dr. Bhargava, really providing critical evidence to the field. So, you've talked about prevention and you've heard sort of nutrition as one additional, armamentarium to the TB preventive therapy. What else can we do to really prevent TB? Like, what are strategies we should be thinking about, and what are some of the research gaps that are part of the TB prevention world?
Well, I think it's a chicken and egg question. So, where does it start? It starts with TB being transmitted. Well, obviously that person got it somewhere, but we have to stop prevention. There has to stop transmission in the community. And if we think about any one person who's diagnosed with TB and how many people have been infected by that, how many secondary infections are there from that person? And we have to do several things. We have to do much earlier case detection. Most people with tuberculosis have been symptomatic before they're diagnosed for several months, and sometimes for many months. And during that time, they're transmitting infection. So earlier diagnosis is very important. And then better contact evaluation and doing contact evaluation beyond households. Household contact evaluation is really important. It's very high yield. There are people who can say, oh, we need to forget about that and go into the community. No, we shouldn't forget about it, but we need to go beyond it and into the community and figuring out better ways to find out where transmission is occurring in the community and preventing it, or finding the people in the community who have been infected and giving them preventive therapy. So I think strategies for implementing earlier case finding are incredibly important. Strategies for figuring out how to track transmission in the community and either interrupt it or at least identify people who will benefit from preventive therapy. And then, it's interesting, the ration study that Dr. Swaminathan and her colleagues did is spectacular. And you think, well, how do you take that to scale? Well, you actually take that to scale at a population level, not at a contact level. And programs can take it to scale, with context, but nations can take it to scale with the population. So that's clearly important. I want to add one thing about that, though, that I just think is very interesting. If you go back to studies that were done in the US Navy in the 1950s and 60s, BMI is really important as a risk factor for TB, and it's not necessarily malnutrition. People with low BMI are at greater risk of getting TB, whether they were infected when they went into the Navy or whether they became infected. Tenfold higher than people with high BMI in terms of their risk. When all of these sailors were in the Navy, they all got good food and they all got the same amount, and they were all adequately nourished, but people with low BMI had much higher rates of TB. So there has to be something we can learn from that, you know, in terms of pathogenesis, because it's not malnutrition, at least in that setting. So even with good nutrition, low BMI is a risk factor. So I think that's just an interesting aside. But yeah, those are the things. And obviously a vaccine. You know, we have the most widely used vaccine in the world done work. And just this week in the New England Journal of Medicine, the BCG revaccination study looking at whether BCG prevented infection, showed that it didn't. So that was a big disappointment, not a big surprise. We need a better vaccine.
Well, speaking of vaccines, we just heard from Dr. Swaminathan that we're still not meeting our goals for investment in R&D. And so I want to ask both of you, starting with Soumya, what can we do to really encourage more financing and more investment in a disease that's the #1 infectious disease killer currently, back to taking its place #1 when COVID was #1 during the pandemic, but it's back to being #1. It's an age-old disease. How do we make it important? How do we make it something that people care about to invest resource dollars and research investment? What are your thoughts, Dr. Swaminathan?
Well, I think to most people in this room, it would be obvious why we should invest in a better TB vaccine and other innovations to make treatment shorter, more convenient, less toxic, particularly for children. And we have made progress. We've got the BPAL-M regimen, and that's thanks to organizations like the TB Alliance and others, that have been funded and that have enabled also collaboration with the private sector and enable these molecules to move through a number of clinical trials. But I think several reasons why the world should be investing more in TB. Firstly, it is an airborne infection, and therefore, just like COVID, it's not as infectious, of course. But if there's TB in some part of the world, then everyone is at risk, and particularly it's true for drug-resistant TB as well as drug-sensitive TB. The other, of course, is that TB affects the most productive age group, and we know that in many countries where TB is endemic, the men in the age group of about 40 to 55, that's the peak age group and sex for TB incidence, and so that's hurting the economy. So I think there's also an economic argument to be made for why there should be investment, and particularly I think now countries like India, Brazil, China, South Africa, Indonesia, Nigeria, where the high burden of TB, but there's also a lot of resources, should be putting more investment into TB R&D. And finally, I think philanthropy, of course, must step up now, particularly since governments are not increasing or actually reducing their investment in infectious disease R&D, including TB. I think there is a scope for philanthropy. Again, philanthropy all around the world. Certainly philanthropy in India is picking up. Philanthropy in the US has always been big, and some foundations or individuals could actually come together and support the cause of TB, and that would encourage others to come up as well. So I think we do need some champions out there, who step up and fund TB innovation and R&D. Great.
Dick, what are your thoughts on trying to get more investment and interest in TB and really helping us to move the needle?
Well, we're 11 blocks down Pennsylvania Avenue from a house where there's a total lack of compassion, total lack of morals, total lack of interest in anybody other than those who already have everything they need. And so that's a big challenge. Okay. Anyone who doesn't know that 1600 Pennsylvania Avenue is an important address in the world. I think the American people have compassion. I think American people care. I think the American people made a terrible mistake a few months ago, but I don't think they've stopped caring. I think the majority of people have compassion. What drives investment is also, I mean, not on the industry side, but just on the public side, is a sense of vulnerability that, you know, this is something that's important to me personally or to us personally. So in New York City in 1991, when a prison guard died of MDR-TB, that said, oh, we don't care if prisoners die, but when a prison guard who's not a prisoner dies, then it's a calamity. And so that generated a huge response, which was very successful. When there was an MDR-TB patient who flew on a commercial airliner from Europe to the United States, it's a panic. When there was an Ebola patient who, you know, arrived in Texas, it's a panic. So when there's a sense of vulnerability, you know, there is a response. But with TB, there's not much of a sense of vulnerability in this country, which has so much to offer. So, you know, I think some of the things that Soumya is mentioning about, you know, economic vulnerability, and, you know, we have an outbreak of TB, MDR-TB in Kansas right now. You know, it's not generating as many headlines as it really should be, but that creates a sense of vulnerability, you know, personal vulnerability. But, you know, when the TB in this country, you know, is something that needs to be controlled at a global level, not at a national level, because we have so many cases of TB in people who probably acquired their infection elsewhere in the world, and that's the strategy that we need. So there's an economic argument to be made for investment in TB. The problem is, you know, if you think about COVID, so $100 billion invested in COVID vaccine research in the year 2020 alone, compared to $140 million for TB vaccines. But everyone felt vulnerable, and companies cared, and people cared, and so there was a good investment case for it. The investment case for TB vaccines isn't the same. So, you know, companies aren't going to step in. Some companies, you know, like Moderna, are trying mRNA vaccines, and they're doing it because they believe in innovation, and they think, you know, they have a portfolio of products that are innovative, and if any one of them succeeds, they'll be happy. But their cancer vaccines, you know, are probably where their future earnings will come. So.
Great. Well, I want to open it up now, open it up to the floor for any questions regarding TB. And I know we have at least one audience member who had a question. So I'll give him the mic to start. But others, looks like several of you. So please come up to the mic so we can have your questions in.
Thank you. Thank you for the nice conversation. I have one positive question and one negative comment. The positive question is midday meal schemes were started decades ago in many states in India, Tamil Nadu being one of them, with the idea of improving nutrition for kids who go to school. It was seen as a way to encourage children to come to school, but there is also the nutrition. I think we need to see how that has helped in promoting health and across the country, whether that is effective, is being done. Of course, there's always corruption, politics, and so on. The kids were not actually getting the good food they were supposed to get, and people were benefiting, and that's the negative part of that. But that's one thing, because nutrition was mentioned and BMI was mentioned. The second thing is, and please don't mistake me for making this comment, I go to India frequently, like most of us, but I think the notion of physical separation is not there. I stand in a queue and I try to give, not 6 feet. I don't want 6 feet COVID thing. I say, okay, give me 2 feet, I move the airline and the person moves. And I move, the person moves, I can't go anywhere. I feel blocked. And I think that's one of the issues, right? The second thing I've noticed is people don't cover their mouth when they cough. Just cough. I'm petrified. I'm afraid to go to temples. Big temples have hundreds of people going in to see the gods. I want to go, but something has happened. I came to this country in 1977. It's what 40-some plus years. I'm so scared. I think, is there anything we can do in terms of public education? These 3 things which will help decrease infection and so on. Again, thank you. I wear mask every time I go. Even here, some of us are a little bit more susceptible. I've been a diabetic since 1992, so I'm careful, and I see that's one of the things that will create issues. So I think these are low-hanging fruits. So what can we do and why it's not successful? But I still see people trying to touch me when I'm.
All right, well, we'll come to that point. I'm going to take another question. So that was Dr. Rama Chalapa, a data science AI expert, and also we have now Dr. Mathuram Santosham from the School of Public Health. So go ahead, Mathu, with your question, and then we'll ask our 2 speakers.
Thank you. I hope I don't sound too stupid. I'm here with 3 giants in tuberculosis, and I have not worked on TB ever, but I have received the BCG vaccine. I was a little disappointed to hear I don't keep up with BCG, with tuberculosis literature, but you just mentioned the latest publication, which I haven't read, said that BCG does not work. Is that what I heard?
Well, that's a whole interesting topic. So we have 2 questions. I'll have first, Dr. Was that your question? Was about
and I have a comment.
Okay, please go ahead, your comment, and then we'll have the 2 questions answered.
Okay. My comment is about funding. And again, I might sound very naive. As you said, Dick, the American people are good people. And I think people around the world are good people. And there are some good people with deep pockets. And I do believe, and I'm not just speaking, parenthetically, I have actually done this with our population. We lost lots of funding, just like everything else from NIH. As you all know, I worked with the Native American population. We were able to raise significant amount of philanthropic money to cover the deficit. We as academicians are not used to thinking about life that way, but we do need to think outside the box in this kind of crisis. There are good people out there. There are good people who care, but it's how you present your story that matters a lot. It's not something you just go and have a conversation. It takes a lot of preparation. It takes a lot of time to understand what that person's priority is. But believe me, it works.
We're going to talk to you about that after, Mathu, and have you come and help us on the effort. To answer the sort of, I guess, 2 questions or sort of comments made, Dr. Soumya, about sort of infection control space, thoughts on that front, and covering. I mean, what kind of education should be done for public to sort of be thoughtful about coughing?
Yeah, so I agree with the comment that I think we've forgotten all the lessons of COVID. Whereas in large parts of Southeast Asia, you find that wearing a mask is very common, and it's not, considered at all stigmatizing, and it's people just go about it. And I really believe that not just TB, but even for the burden of respiratory infections, especially when we live in a crowded country, and we very often find ourselves in situations where we're in a crowd and it's not as well ventilated as it could be. Masking, and then simple things like not covering your mouth and nose when you're coughing or sneezing. These are things and washing your hands regularly, and all of that really has to be habits that should be inculcated from childhood. And I think we could also do a lot more public health messaging about it than we currently do. So I think that is a good point. I do think that we also need more research into transmission of TB, because we've had a lot of data coming out of South Africa, which is very intriguing. The fact that so many people walking around, you're able to grow tuberculosis, from their exhaled breath. We know that there's a lot of subclinical TB, also from the prevalence surveys that were done in India, both state level and national level prevalence surveys. Almost 40% of the culture positive TB was in people without any symptoms at all and who had absolutely hadn't considered visiting a doctor or anyone because they just didn't feel sick. And so given that situation, it becomes very difficult, to talk about elimination when we don't have a good diagnostic protocol. Again, X-raying 1.4 billion people is not a realistic target either. So we've really got to do a lot more research into where transmission is happening, who's most at risk, and what are the most cost-effective strategies of finding them. On the BCG, I'll let, I think, Dick take that question, just that there was a big trial done in India, one arm of which had recombinant BCG. The other arm had another inactivated TB vaccine and versus a placebo. This was done in household contacts, about 12,000. And I think the results have been submitted for publication, but essentially BCG did not have the desired effect of reducing incidence among household contacts.
Great. Do you want to add to the BCG story, Dick?
Yeah, well, I mean, the latest study was funded by the Gates Foundation and done in South Africa, and just looked at whether BCG could prevent sustained IgG conversion, a conversion of a TB infection test, and it didn't.
So it wasn't just on the vaccine. It wasn't double-blind prospective study, or was it meta-analysis?
Oh, no. This is a clinical trial, double-blind, placebo-controlled.
Because
And this was in adolescents. I mean, so it wasn't the very young. It wasn't neonates. So just to be clear, yeah.
And I think it's worth emphasizing, BCG is the most commonly used vaccine in the world. It's given at birth, and when given at birth, it prevents child mortality. It doesn't prevent child mortality primarily because of TB. It prevents child mortality from gastrointestinal infections, lung infections that aren't TB. And it does have an impact on disseminated TB in children. So that's why it's a good thing. It's part of the immunization program globally. It's not good for controlling TB. So.
And it also helps in bladder cancer treatment.
Yes, that's
but
not why it's given it.
No, I understand that. Amita, you're doing amazing work on infectious disease and particularly TB. Is this because we have more cases of variant mycobacterial infection that we are not seeing that effect? Like microavian and other species?
No. 90% of the TB that occurs in the world is fully drug susceptible, regular old-fashioned TB. 4% of the TB in the world is multi-drug resistant, and that gets 90% of the attention. But most TB is not drug resistant. It's not a new variant. It's just TB and what it is.
And any new things happening for developing new vaccine for TB? Because that's, we are not going to be able to do that unless we have mass vaccination for prevention. And if BCG did not work, then I think any efforts underway?
Well, that's we can give a short answer, and I'm happy to answer that. Let me get one more question, because it looks like someone's behind you to ask another question. And please state your name as well. Thanks, Raj.
Hi, thank you. I'm Amita. I am actually working with a researcher at UMBC who has developed a quick diagnostic for TB detection. My question for Dr. Swaminathan is, if we're talking about subclinical TB, right? How do you get to early detection? Can we have programs in the country where everyone gets tested? How do we make that happen?
Okay, great. So I'll just answer really quickly the TB vaccine question. There are at least 13 candidates that are in human clinical trials. We just unfortunately heard that the BCG revaccination trial now, both for infection and what Dr. Swaminathan gave us a little bit of a primer for prevention of disease, has not worked. There's also trial data to look at another recombinant BCG for prevention of recurrence, which also results are anticipated. There are a variety of other what we call protein adjuvant based vaccines that are being studied. Something known as N72 is in a big phase 3 trial right now. They finished enrollment. We hope to have in a few years a new result from that very large trial. There are also other proteins of conjugate vaccines known as ID93 that are being tested, as well as vector vaccines and mRNA. So a lot is happening in that field. The challenge is you need money. You need a lot of money. Okay, you just heard 100 billion for COVID, 140 million for TB. So we need more money. And they take a long time to do vaccines. Really, you need a large sample size to really be able to see a result. So we have a ways to go on the TB vaccine field. I will now switch it over to have Soumya and Dick say the last word of what can we do? I know we could keep going, and I wish we had more time, but I've been told time up. Would you like to just sort of have some closing comments, Dr. Soumya, and feel free to answer the question about asymptomatic subclinical TB and then Dick.
So I think at this point, the best way to diagnose subclinical TB is probably through an X-ray, because what we found in the TB prevalence survey that was done in India was that about 40% of the cases that were ultimately detected to have TB were only detected because they had had an X-ray as part of the screening test. So if they'd only had a symptom screening, they would never have had a sputum collected. So now, as part of the strategy of the National TB program, X-rays are being more widely deployed, particularly for the high risk or vulnerable groups like the household contacts, as well as people who are undernourished or alcoholic or diabetics. So there's a protocol for that. And the good thing now is, again, because of the innovation of having these handheld X-rays, which are very small, quite lightweight, can be carried in a backpack on a motorcycle and taken into the remote rural areas, battery operated. And you can actually have an AI algorithm reading the X-rays. So you could have a technician go out and X-ray a whole community, and the AI would actually read those and in a couple of minutes have the results back, so that the technician would then know who those individuals were from who needed further examination and sputum collection and so on. So I think that's a huge advance. And if we need to do the cost effectiveness again of different strategies, so there's a lot of implementation research going on now to see which strategies, who are the population groups where this kind of going in and doing a mass X-ray screening followed by sputum examination would be cost effective in finding more TB cases, because to achieve the goals of elimination, obviously we've got to go out and do active case finding so that you can actually detect and treat more people that are out in the community. But this is where a lot more research is needed in different settings, I think at different levels of TB prevalence in the community, and targeting sort of different groups and using different algorithms. But till we have a good blood test, and a point of care test, a urine or a blood test that can actually screen for TB, I think X-ray is probably the best tool we have at the moment. But Amita, do you want to add?
No, there's a whole, we've been talking about AI, and we know we have Curia with many others looking at this area of how we can use AI to speed up both, I think, new diagnostics and platforms. Dick, thoughts, closing comments?
Yeah, 30 years ago, the World Health Organization said that no more research was necessary. We knew everything we needed to know. Long before your time there, Soumya. And that we just needed to implement what we knew. Well, that was clearly wrong. Innovation is incredibly important, and is as important as it has ever been. And frankly, there's no substitute for public investment in innovation. You know, the Gates Foundation can't fund everything that everybody in the world wants to do, even though we think they can. We need public investment. And as I said earlier, I think people in this country care. I think they have compassion. I think they have seen the benefits. And I think we're in a really bad period where public investment has been decimated, but I think it has to come back and it can come back. I think all of us as, you know, people who are in this country need to do everything we can to advocate for the return of science. You know, we're sitting in Johns Hopkins University, research saves lives. That's our new motto. That's our new campaign. And it's important because I think people in this country know that. And it's going to take a while to convince 11 blocks down the street that we need to continue investment in innovation because research saves lives. That's my thing.
Great. Well, on that note, a research saves lives. Please give me thank you so much for coming, and thank you so much for being up on a Saturday night, Dr. Swaminathan.
Thank you. It was a pleasure.
Thank you. And thanks all of you. I know there were so many more questions. You can feel free to reach out, and I'm going to have to talk to you about how we can get success in more fundraising. So thank you. Good night, everyone.
Bye-bye.
Yes, we'll have to send this to you, Soumya.